were discussing about clinical diagnosis. Okay, so clinical diagnosis, for diagnosis, what I have told you, to diagnose a disease, you should know the terminologies. You should know the name of diseases, various diseases, periodontal diseases, gingival diseases. So all these diseases you should know, and for that purpose, you should know the classification of periodontal disease. Okay, so periodontal disease classification, which was taught you people in third year, you read it again because that is more important part from your clinical diagnosis point of view. While writing diagnosis in your case history, it is going to helpful to you people. See, clinical diagnosis topic is very important from point of view towards your case history. You people have to record case histories. So while recording case history, most of the part from clinical diagnosis will be discussed, and that will be helpful to you people while writing your case history. So in case history part, again, I'm just repeating or revising the part which was taught in the last lecture. That is case history or even while clinical diagnosis, you should have some general information of patient in that name, age, sex, and first part like chief complaint, which should be written in the patient's own word. After chief complaint, you have to write history of present illness. After history of present illness, you should record patient's medical history, means systemic history, then past dental history, then oral hygiene habits of your patient, oral hygiene habits in form of whether patient is having any tobacco chewing habit or any other habits, his brushing habit, his type of brush, what he uses, all these things you have to record under that part. And then next part will be your extraoral examination followed by intraoral examination. Again in intraoral examination, you will check all surrounding part or lining mucosa or floor of mouth, everything that you are going to check. After that, the next part will be your teeth, present of teeth examination. In teeth examination, you have to write about trauma from occlusion, type of bursting diseases, if patient is having any accretion, abrasion, abstraction, or these kind of diseases, then you have to record under that particular condition, type of contact, pathology. So all these things you are supposed to record in the teeth, whatever examination you people are going to do. After that, you have to write about gingival status of your patient. So gingival status followed by periodontal status, followed by mucogingival status, and then your provisional diagnosis, then final diagnosis. After provisional diagnosis, you people have to refer patient for other radiographic examination or laboratory examination, whatever needed, and then you are supposed to write the final diagnosis based on that. Concluding that all these things, you will reach to a particular diagnosis for that condition. So you should know all pathologic conditions. Till now, in third year, you people have read about or you people have gone through the periodontal conditions, healthy, that too health. So in health, what is seen, gingiva, how the healthy structures of gingiva or physiology of gingiva, physiology of PDL, physiology of alveolar bone, physiology of cementum, and after that, the part which is taught to you is pathology. Before pathology, again, causative factors or associated factors which initiate the disease, followed by you should know how to diagnose a condition, and after diagnosis you are going to start with treatment plan and related factors. Okay, so today we are starting with clinical diagnosis again, next part of clinical diagnosis. Till now we have completed up to teeth examination. Now start with the gingiva. So in gingiva, what I have told you in the last class, that gingival status is a chart. In that chart, you have to enter the tooth number by seeing the one side like color, whether there are color changes in that patient. So you have to examine, you have to enter particularly color change, which kind of color change you have observed. You have to write about that color change in the that particular box. Means if it is maxillary anterior, maxillary posterior, or mandibular anterior, mandibular posterior. So all that things you have to write in the color part of gingiva. So color changes you have to write. Then contour, you have to write about contour. Contour, usually you people have seen that contour is normally scalloped. Scallop means what? That on radicular area, it has a slightly whatever gingival margin is there, it has moved apically, means and in the interdental region again it is elevated. So embrasure, you people have seen the fort has embrasures, or you people have seen any big buildings, or previous in the ancient times the fort has these kind of embrasures, elevations and slightly depressions. So similar kind, see here in this pic also there are embrasures, or this is scalloping, which we call it as a scallop margins are there. So these scallop margins becomes changes, means whenever pathologic conditions are there, there are changes in this condition. See here on this next pic, you can see here scalloping is sometimes accentuated. Here it is aggravated scalloping. Here there is loss of contour is there and loss of scallop is there. Contour is not proper. It is not scalloped one. Here some changes are there. So here cleft is also, people can see here cleft. Clinically cleft means what? Cleft is a break in continuity of margin of gingiva. If cleft is there, your probe will go in this narrow cavity. So this is cleft. So Stillman's cleft, Stillman is a periodontist who invented this cleft, or invented this, he showed this finding first time. So cleft is a break in continuity of margin of gingiva. There is no continuous margin. So because of that, there is cleft formation can be seen in these areas. So cleft is a break in continuity of gingival margin. Normal gingival margin is a scalloped one. Still here, it is slightly aggravated margin is there, slightly accentuated. In physiologically, in canine region, there is accentuated margins are there because of corner tooth or convexity of canine region will accentuate the margin of gingival tissue. So usually the pathologically contour will be slightly, you people can see the contour change in the contour is usually Stillman's cleft. You have people have to write contour alteration in the contour like straight, or alteration flat contour can be seen, or Solon papillae. This papillae, Solon papillae is not exact terminology to describe contour. Contour can, you people can write about the alteration in the contour. So margins, when you are writing shape of gingiva, that time you people have to use these terminologies, bulbous or Solon papillae or rolled margin. Usually marginal gingiva is a knife-edged. You people can see here, it is a knife-edged margin of gingiva. Here absolutely healthy marginal gingiva is there. But here you people can see these rolled margins are there. So this terminology, rolled margins, or this Solon interdental papillae, or ballooning of interdental papillae, all these are the terminologies which describe the shape of gingiva. Okay, so shape of gingiva is described by these terminologies. Stillman's cleft and Meckel's festoon are another conditions which can be entered under the heading of contour. So if this kind of cleft is present in your gingival status, you people will write in front of contour only. In front of contour, you have to mention this cleft. Okay, all of you understood? We have seen color, last time consistency, and now we have seen contour of gingiva. Okay, so color, contour, consistency, 3 C's are there which are important. Color, usually it is defined by 4 factors, that is epithelial thickness, gingival epithelium, thickness of gingival epithelium, then vasculature in that particular area, melanin pigmentation in that region, and then keratinization. So all these things will decide color of gingiva. And whenever pathologic conditions means gingival inflammation is there, that time what happens? Extravasation of fluid occurs. Extravasation, inflammation means what? In pathology, it is taught to you people. In inflammation, what happens? Extravasation of fluid. Polymorphonuclear leukocyte, they migrate from the vessel wall inside the area of bacterial insult. The same time, extravasation of fluid. Fluid means what? From the blood vessel, the fluid will come out. Extravasation of fluid. So that whatever fluid it accumulates intracellularly or extracellular spaces, and because of that, what happens? The color of gingiva also get changes because of fluid or blood vessel. Whatever plasma fluid or blood, it comes out through the vessel wall. It get accumulated and it gives the color to that area. So because of that, color changes you people can see in acute condition, bright red type of color changes are there, and in cases of pathological changes, like chronic conditions, this extravasation of fluid or fluid which is accumulated will get later on converted into bluish tinge because of hemoglobin. It get break down the pigment of that hemoglobin will get break down, and ultimately that bluish color will come to the margin of gingiva. So bluish tinge can be also seen in chronic type of conditions. Inconsistency, normal consistency, you people can see here, firm and resilient, or which is tightly bound to underlying periosteum or underlying structure. So this consistency also because of fluid get accumulated sometimes in inflammation. So that time consistency becomes soft and edematous. Here in this condition, you people can see soft and edematous condition. So this typical picture of edematous consistency. Sometimes fluid is not a cause of that edema or enlargement. Sometimes fibrotic enlargement can also be seen, and that time consistency is not edematous. It is slightly fibrotic type of consistency. Whenever fluid accumulation or fluid component of that area is more, that time consistency becomes soft and edematous. If fibrotic component in connective tissue get more and more formation of fibrotic component is there, or reparative changes. Reparative means what? When tissue is trying to repair itself, that time fibrotic component will be more. So that time consistency again, it is not a soft and edematous, it is leathery or firm type of consistency can be seen. Then contour of marginal gingiva, it is scallop contour is there. Scallop means like this, like a embrasure. So scallop contour sometimes get altered. There may be formation of cleft. There may be alteration in the contour. Flat type of contour is there, or accentuated contour can be seen here. Accentuated contour, which is physiologic one. Other than that, festooning like this, Meckel's festoon, we can call it as a Meckel's festoon. Life preserver ballooning of marginal gingiva is, if it is seen, then we will write it as a Meckel's festoon. So you have to identify the condition, clinical signs and signs, and you have to write in front of them. Then surface texture of gingiva. Surface texture, normal surface texture. In surface texture, you people will write about stippling. Stippling is nothing but alternate elevation and depression which is seen because of the tightness or firm part of gingival tissue. And this stippling is seen mainly in attached gingiva and some part of interdental papilla. Here it is not properly visualized, but when we see in normal light, and we dry gingiva with a cotton swab, that time you people can see orange peel type of appearance on the gingival tissue. Alternate elevation and depression can be seen on the surface of gingiva. So that surface texture or stippling is that type of appearance, we call it as a stippled appearance. That is surface texture of gingiva, normal physiologic surface texture of gingiva. But because of this edema and soft tissue or ballooning of that area, you may will not, obviously this stippling is not seen, it is not obvious. So you people have to write about surface texture, that stippling is not seen or stippling is absent in that particular region. So you have to write about that. Then bleeding, you people can see and write about that. Then probing depth, bleeding on probing, we will see in the next part. So tissue resistance means what? Present of probe penetration. It is actually related with the consistency of gingiva. When you probe or when you press that particular area of gingival tissue, if it is pitting or non-pitting type of edema, that you have to mention. That is tissue resistance, nothing but tissue resistance. Probing depth, I'll discuss separately. Bleeding on probing is a sign of inflammation. Actually, absence of bleeding is a good sign of healthy tissue. But presence of bleeding, it doesn't mean that inflammation is there in that region, because sometimes you may injure gingiva and bleeding can occur. There are various causes of bleeding. Sometimes physical causes are there, like because of trauma and all, while brushing or while eating. Sometimes there may be trauma, physical trauma. And sometimes when bleeding on probing, when we write about bleeding on probing, you have to move probe in the sulcus along the lateral wall of sulcus. Means insert the probe and move towards the circular side, not towards the tooth side. And you have to move gently, run a probe gently and in the sulcus. And if bleeding is present, you have to observe for 30 seconds. And after 30 seconds, if oozing or a type of bleeding which occurs, you have to write about that. So bleeding on probing is a sign which you have to check. Then probing, we are going to discuss it separately. So there are three C's, three S in surface texture. Then shape of gingiva. In shape of gingiva, I have told you that marginal gingiva, rolled margins can be there, or ballooning of gingiva is there. Then if after shape, size of gingiva, size, when you are writing about size, it indicates that some total volume of gingiva. If size in enlarged tissue, size is definitely increased. So you have to write about increased some total volume of gingiva in that particular region. After size, you have to, after three C's, three S are over. Now one P is there, that is position of gingiva. So position, normal position of gingiva or marginal gingiva, where it present is coronal to CEJ. Always, most of the times in normal physiologic condition, this margin of gingiva is always coronal to CEJ. But in inflammation, there may be margin or sometimes recession is there. In that area, you have to write about apical to CEJ. You have to write the position of gingiva with reference to presence of CJ. If it is coronal to CJ, you have to write coronal to CJ. If it is apical to CJ, apical means what? It has moved along the root surface. Then apical to CJ. In that way, you have to mention. So this will complete your gingival status. All of you understood? Anyone is having any query? Please let me know some, at least some responses. You people are listening or not? How I will observe that? Hello? Nobody is listening, I think. At least respond something. Have you understood?
Yes, ma'am.
Okay, thank you. Who is there? Who has responded? Okay, we'll move. See here, color changes. Here, this picture will show you this purulent exudate which comes out when you are writing this gingival status. Just below the gingival status, you have to write about exudate, presence or absence of exudate. In that cases, how to check exudate is, you have to gently move the soft bed of your finger, soft bed of index finger. You have to move from mucogingival junction towards the marginal gingiva like this. In this manner, you have to move the soft bed of gingival, your index finger. And if purulent exudate comes out through the sulcus or through the margin, then you have to write about the exudate present. See here, in this picture, you can see exudate or purulent part which has come out through the sulcus when you move along the mucogingival junction towards marginal gingiva. So purulent exudate comes. So Meckel's festoon and Chilman's cleft. Here I have shown you Meckel's festoon and Chilman's cleft. Here initiation of cleft you people can see here. Even marginal gingiva is also changed. Shape of marginal gingiva. So bleeding on gentle probing, people can see oozing of blood from the sulcus. Now we'll discuss about periodontal status. Okay, so periodontal status, mainly 4 or 5 findings are there which indicates that whether that tooth is associated with periodontitis or not. The gingival finding will give you diagnosis of gingival status. Okay, but if that area is again further progress, inflammation has further progressed to underlying periodontal structure, then your diagnosis will shift to periodontitis, and it is based on the area of involvement. Okay, so it is based on the area of involvement, localized or generalized. If lesser than 30% teeth are involved or area is involved, then you can write about localized periodontitis and generalized gingivitis. Okay, localized periodontitis in relation with that particular area, particular tooth, that is 4131 or whatever it is. So localized periodontitis with 3141 and generalized gingivitis with generalized gingivitis. That will be your diagnosis. If all area, almost whole area is inflammation is progressed till underlying periodontium or underlying periodontal tissue involvement is there, then your diagnosis will be generalized periodontitis. Okay, got it? So there may be diagnosis can be up to gingivitis. If inflammation is restricted till gingival status or gingiva, then your diagnosis will be chronic generalized chronic gingivitis. If it is localized area involvement is there and periodontal structures are involved, then localized periodontitis with generalized gingivitis. If overall area is involved and periodontium is inflamed, then you have to write your diagnosis as a periodontitis. But to write periodontitis diagnosis, which part will show you that periodontium is affected? Till gingival status, these findings means color, contour, consistency, surface texture, size. When you observe all these things, you will reach to diagnosis of gingivitis. So to reach to periodontal diagnosis or diagnosis of periodontitis, which factor or which findings are going to help you? Any one of you can tell me? Prajakta, Mandar, Trupti, any one of you can let me know which findings are going to tell you about periodontal status? Any one of you? अरे काहीतरी बोला रे बाळांनो. हा काय
loosening of periodontal ligament.
काय म्हणतोय मंदार? आय एम नॉट ऑडिबल. हा परत एकदा बोलशील?
Loosening of periodontal ligament.
See, gingivitis, when you are writing or you have to reach the diagnosis of gingivitis, which findings you are going to observe? Color of gingiva, contour of gingiva, right? All of you got this point? In the similar manner, to reach to diagnosis of periodontitis, you have to check probing depth in that particular region. Okay, so probing depth, then clinical attachment loss. Clinical attachment loss, which we call it as a CAL. So clinical attachment loss, then periodontal pocket depth or probing pocket depth, then pathologic tooth migration, trauma from occlusion, then mobility and furcation. These are the factors which are going to tell you about periodontal condition of that particular region. समजलं का तुम्हाला? अरे तुम्ही काहीतरी रिस्पॉन्स द्या. तृप्ती, राणी, Have you got understood this, Mayur?
Yes, ma'am.
What I told you, that to observe periodontal findings means to write diagnosis of periodontitis, you should know some findings. On what basis you are going to write? कशाच्या आधारे तुम्ही डायग्नोसिस लिहिणार आहेत पेरिडोंटायटिस? तर कशाच्या आधारे लिहिणार आहेत? तर फर्स्ट इज प्रोबिंग पॉकेट डेप्थ, second is clinical attachment loss, which we call it as a CAL, then percussion involvement, then mobility of that particular tooth, and trauma from occlusion, pathologic tooth migration. So mainly 5 findings are there: pathologic tooth migration, probing pocket depth, clinical attachment level or clinical attachment loss, then mobility and percussion. All of you got this thing? या फाइंडिंग्स जेव्हा तुम्हाला पॉझिटिव्ह येतील, सपोज प्रोबिंग पॉकेट डेप्थ इज मोर दॅन 3 mm. व्हॉट इज नॉर्मल जिंगेबल sulcus depth? इट इज अप टू 3 mm. वी कॉल इट एज जर प्रोबिंग डेप्थ 3 mm असेल तर वी विल कॉल इट एज अ नॉर्मल फिजियोलॉजिक sulcus. If probing depth is more than 3 mm and it has reached to 6 mm, 7 mm pocket आहे त्या एरियामध्ये, then what is your diagnosis? Periodontal pocket, if it is seen, then that particular tooth is associated with periodontitis. Okay, got it? Clinical attachment loss means what? Clinical attachment loss, we are going to discuss it again. But probing depth, normally probing pocket depth is, we write at up to 3 mm. Normal sulcus depth is up to 3 mm. But when it moves more than that, if sulcus, in the sulcus, if it is moving more than 3 mm, 4 mm, 5 mm, provided that gingival enlargement should not be there and pseudo pocket should not be there. Pseudo pocket means काय? Margin of gingiva will move coronally. In gingival enlargement, what happens? Gingival enlargement means काय? Enlarged gingiva असते. So margin of gingiva moves on the crown surface. So because of that, the feature or a probing depth may not be true. Because of that, we call it as pseudo pocket. Okay, got it? समजलं सगळ्यांना? हे नसेल समजलं तर प्लीज बोला. So probing depth, clinical attachment level, then pathologic tooth migration, tooth mobility and percussion. All these 5 features are going to tell you about the status of periodontium. Got it? So periodontal probing, it depends on many factors like surface irregularities. Surface irregularities may be because of presence of calculus. Okay, percussion involvement, then subgingival deposits. Subgingival deposits are nothing but calculus. Calculus will obstruct the probing. Because of calculus, your probe will not reach to the base of the pocket. Then margins of restoration, presence of periodontal pocket inflammation, means periodontal probing will affect on all these things. Probing depth. So there are 2 different pocket depths are there. First, we call it as a biologic or histologic pocket depth, or clinical or probing depth. So biologic or histologic means what? It is taken in a histological sample, a section. Means it will give you correct depth. So when you take a section, histological section, you can measure from margin to the base of the sulcus. Probing depth means what? Any one of you can tell me what is probing depth? How it is measured? When you insert this probe in the sulcus, you measure from margin to the base of the sulcus, right? So at the margin, whatever probing marking or calibration is there, from there to the base of the sulcus, this tip of probe, you will measure that and you will write it as a probing depth. But histologic and biologic, you will take a tissue sample, you will measure from margin to the base of the sulcus or base of the pocket, and you will write. So it is more accurate, biologic and histologic. But in clinic or in OPD, we record this clinical or probing depth. With the help of this ad hoc instrument, we call it as a probe. Got it? So how probing is done? So probe should be always inserted parallel to the long axis of the tooth. It should not be perpendicular. It should be parallel to the long axis of the tooth inside the sulcus. And there are 6 different sites where you measure your probing depth. But in your case history pro forma, only 4 areas are there where you measure. That is mesial, buccal, lingual, and distal, like that. But in 6 areas you are supposed to measure, that is distofacial or distobuccal, buccal, then mesiobuccal, mesiolingual, lingual, and distolingual. So all these 6 areas are there around the tooth where you measure probing depth. आणि त्या पर्टिक्युलर एरियामध्ये सपोज इफ इट इज मोर दॅन 3 mm, then only you have to write pathological findings you are supposed to write in that region. Okay. So probe is inserted until the tip encounters the resistance of junctional epithelium that forms the base of the surface of periodontal pocket. The junctional epithelium feels soft and resilient when touched by the probe. The probe is not removed from the sulcus or periodontal pocket with each upward stroke. Removing or reinserting the probe repeatedly can traumatize the tissue. And walking of probe, we call it as a walking of probe. Without lifting from the pocket, you can just move like this inside the sulcus. You can move, you can record the pocket depth. Without coming out of sulcus, you have to just walk a probe inside the sulcus. Got it? So probing interdentally, how you have to insert, slightly angulated, you have to insert and you have to record proximal area. So these are the how exactly you should probe. So walking of probe, you have to insert the probe, calibrated probe. Calibrated म्हणजे ज्याच्यावरती markings आहेत तो probe. So with the markings, the probe which is having marking, that probe should be inserted in the sulcus and it should be measured properly with the help of sulcus. Distance from margin to the tip of probe. So probing, what happens sometimes there should be ideal probing force is required when you probe. How much it should be? Any one of you can tell me? Probing depth, probing आपण चेक करतो तेव्हा probing force किती अप्लाय करतो? Any one of you know? माहिती आहे का कोणाला किती असतो probing force? It should be 20 grams or 0.75 newtons. आता 20 grams कसं ओळखायचं? Any one of you? To identify that 20 grams you are inserting, is it possible every time you insert the same amount of probing force? It's very difficult. So there is a test, nail bed test, we call it as a nail bed test. तुमचं thumb nail आहे ना, त्याच्या बेसला you have to insert the probe, and the point when you feel some irritation, that much amount of probing force you have to insert while checking probing depth. Got it? So probe should be cylindrical or tine probe tip. Tip diameter should be 0.5 mm. NIDCR or ISO standardization of a periodontal probe. Constant probing force should be 0.75 Newton. Here slightly it is wrong. 0.75 Newton or 20 grams. 15 mm scale.